snowfall in Toronto history. So you're part of the toughest cohort we've ever had. So welcome. We'll give it another minute or so before we start. Brandon will kick us off with an icebreaker. Maybe we'll wait till 103, Brandon, once it kicks in on that time. But
Yeah, no problem.
hopefully everybody is keeping warm. Also, if there's anybody who is new, if this is your first week, if you weren't able to attend last week, welcome to MobilizeU, an enjoyable and informative experience, we hope. Um, my name is Michael, and got Brandon
Yes, nice to
riding
meet you all.
riding shotgun with me. So
If you ever have any questions or you feel like you're not sure about anything, my email is there as a point of contact, and I'm willing to jump on a call to show you guys how to work around the system. So today, after Icebreaker, I'm gonna kind of walk us through e-class, kind of show you guys where to find everything kind of quickly so that we can ensure that everybody can see everything.
awesome.
Alrighty, so I'm gonna share the Icebreaker.
Yeah, I think we're good to go.
So today our icebreaker is with this like cold weather and all this snow. Just want to ask you guys, what's your cold weather beverage? What gets you warm? What do you drink in this minus 15 that we're in?
Good to go. Pretty wide array coming in. I was telling Brandon before everybody connected, I've got almost like I've got jobs for all my beverages. Coffee is my wake up beverage, and tea is my I need to feel better beverage. Hot chocolate is my I'm cold, or I feel like I'm 8 years old and I need chocolate, but they'll do one and the same. Thanks, everybody. All right, Brandon, you want to give us the E-class primer?
Yeah, no problem. Just gonna stop sharing here and then share my screen into. All right. So I just want to ask if everybody can see my screen here. I believe so. So we'll start from, once you go to e-class. So logging in, you start off and first thing first, I would suggest is to go to my courses and you'll see MobilizeU Winter 2026 here. So once you click on that, it'll take you right to the class where you'll be able to see your assignments, our recordings for our meetings, and also our weekly announcements. So every week we post a weekly announcement to get you guys ahead. So just want to make sure that you guys can take a notice of this. So if you missed anything, you will be able to find it there. As going down, all of our Zoom meetings are recorded. So you'll be able to find the recording at the bottom of each week. And once you click on it, you'll be able to go right to the YouTube session that is open for the resource. And then you'll be able to access our recording right here. So going back to eClass, you'll also notice that we have an assignment every week, and we try to ensure that we keep it mindful that you can get it done pretty quickly. So we ask everybody to please get a chance and go over and look at the assignments we post weekly, as they will help you moving forward with our course. So yeah, that's pretty much it.
Yeah, thanks, Brendan. If you are not as familiar or experienced with eClass like me, for example, the more you use it, the better you will get at it. But Brendan and I are both available to answer any questions and happy to help. So before I pass things over to Professor Ginsberg, I want to do a quick waterfall exercise. So you're 1 week in now, and I'm sure you're all feeling like I've got the handle of this. We'll do a little waterfall exercise again, and this is probably for all of our benefits. And this is a bit of a self-identification process in terms of where you think you are in terms of your understanding and your journey of knowledge mobilization. And we'll go through a Star Wars theme with this, all right? There are four choices, and they progress from I don't know what I don't know to I'm feeling like an absolute superstar. So the first phase would be the youngling. It's like the little kids that are kind of learning how to use the force. The second one would be a novice. The third one, and we're probably more familiar with this, is a Padawan. And the fourth one is a Jedi. Let's take a little bit of time. We'll type it in, but don't, well, so it's either a youngling, a novice, Padawan, or a Jedi. All right. If you got it typed in, we'll go three, two, one, go. All right. I didn't even put Jedi for myself. There's always things to learn. I appreciate the honesty where for many of us coming at this from a relatively new and fresh lens, I think what I appreciate the fact is that the processes are inherently a little easier to understand than the terminology. And I think as we go through our 8 weeks, we'll realize this. And it's a great segue to our presenter today. Professor Leanne Ginsberg is within the School of Health Policy and Management. And what I've come to realize, she also leads a graduate level knowledge translation course. So for folks in health, you may call this knowledge translation. We are cousins, let's say, to knowledge mobilization. I think the principles and practices are fairly similar. She's also has had a 5-year career scientist award. So this is a journey that Professor Ginsberg has been on for quite a while. So we're really privileged to have her join us and talking about models, theories, and frameworks. I'll admit it's probably not the sexiest topic we're going to talk about over the 8 weeks, but I would argue it's probably one of the most fundamentally critical in terms of understanding the way in which it walks and talks. I mean, it's really kind of like the building the foundation of a house. Nobody says, "Whoa, your house, that foundation is fabulous," but it's a critical component. So, uh, with that, I want to thank Professor Ginsberg for making the time to join us, and I'll pass things over to her for her presentation.
Thanks very much, Michael. Okay, just bear with me for a minute. I figured out yesterday how to share only the slide portion and not my notes. So are you folks seeing my slide there? Okay, are you also seeing my presentation notes?
No.
No, nope.
Okay,
So
perfect.
you have
Just the way we
mastered
want
that.
it. All right. So thanks very much for having me. And yes, I teach a KT grad seminar, and you suggested advertise this to my students, and I see a familiar name in the audience. I won't call them out, but I'm glad to see someone actually signed on. So you've got someone who's got some crossover here, Michael. I guess you'll probably figure it out when you come to my class next week. So yeah, I agree with you. I think that talking about theories, models, and frameworks is definitely not the sexiest part of well, anything really. Um, but I'll sort of do my best to, as you point out, kind of underline the importance of this. And so I do it in a way that's like a little bit I touch on, I'll kind of highlight theories, models, and frameworks that I've used in this my own work in different ways. So they're in a way they're TMFs that are kind of all over the map, but I'll try to in terms of different aspects of implementation and knowledge mobilization and translation. But at the end, I'll try to sort of bring them together in one place for you. And I've got some of the resources here, the references for any of these as well that I'm happy to share afterwards. Um, so with that in mind, I just need to shrink you guys so I can see my tiny little screen here. I'll talk sort of for the most part. And Michael, sorry, just remind me when do you want me to finish talk? What did you like? Can I have 30 minutes? Is that okay?
Oh, absolutely. Yeah. 30 is fine. Not a problem at all.
Okay. All right. Okay. So I'll sort of talk about my work mostly over the last sort of 5 to 10 years. It's taken place within what's called kind of the TREC program of research. So this is a program of research that really focuses on translating research in care for older adults. So, and it's based with Carol Estabrooks out at the University of Alberta, but there's really a kind of a team from across Canada that's worked on in TREC in many different projects. But a big part of TREC is not only the older adult population, but also the translation is key to this. So everything we do in TREC is kind of got a bit of a knowledge mobilization, knowledge translation focus. So let's see, are my slides advancing? Hmm. How's that? Did that move to the next one?
Yes, it did.
Okay, thanks. Okay, so this is a picture from a hall in a hospital that I walked down about a year ago with my father there in the gurney. And this doesn't look like it's a hospital in Canada, but it is. In fact, it's one of our biggest teaching hospitals here in Toronto. Um, and so, the image I think is pretty clearly of a very sort of sad looking physical space, but I think it also reflects sort of the state of our healthcare system in a lot of ways. In a lot of ways, that system is either broken or at least very kind of badly in need of repair. And I that's not across the system. I think there are parts of our system that still function pretty well. Had some experience with the cancer care system with my mother over the last 2 years, and I think that part of the system actually is in Ontario anyway, functioning pretty well. But I don't think anyone would probably argue too much with me if we said that our system is in trouble across the country in many ways. And so I show you this just, I am constantly reminded of why I have the particular professional interest that I do, which is generally in health system improvement. So I see things like this and I'm reminded that, yeah, this is probably an important area for me to continue to look at. And so I think, improving health systems through change is a pretty complex endeavor. It often involves a lot of players, it often involves teams. We're dealing with complex systems. And so this is really the overarching question that I've sort of focused on in my research for the last, 5 to 10 years. And that is this question of, how do teams implement complex interventions that are designed to improve care? Um, and I think that, knowledge mobilization, which is the title of this program that you're all enrolled in, I think improvement, I think implementation science, I think these things are all about, using knowledge to improve the quality of some aspect of our health system. So I think there's a high degree of overlap, and I won't sort of fuss too much about the terminology in this particular talk. We could go into that, but I think it's a little bit of splitting hairs that I don't think we want to do here today. Um, so, in terms of the space where I work, it's really, I would say, this kind of shared space between, researchers and knowledge users. So, this kind of green shared space in the middle, at one point was known very clearly as IKT or integrated KT. Other people talk about it. Michael Gibbons has talked about it for decades as kind of more of a kind of a mode two approach to research use, where we're not sort of preoccupied only with the science, but we recognize that to use evidence, to use knowledge, to improve things, we really have to make sure that knowledge is situated in context and that end users need to be involved in that knowledge use process. So that's kind of the space where I work, and most sort of KT people who describe themselves as KT or implementation science folks would operate. I have scale up sitting over there as a concept on the using knowledge side. I think it is a system issue. It's not generally something that researchers concern themselves with, but I think answering research questions like I do that ask about things like how does implementation occur, that can be really valuable for understanding how the system might ultimately scale up things beyond a study context. So that's just sort of a brief kind of where I would situate my own work. Um, this is just sort of like a tiny bit about who I am and how I got here. I think anybody who studies implementation science, KT, KM, we come from a really broad range of backgrounds. It's by definition sort of an interdisciplinary field. You don't have a lot of people who are actually trained in this area. We tend to be trained in other root disciplines and then end up here. And so my sort of first foray into research as a independent researcher, if you will, was when I was a doctoral student back in 2000. And at the time, performance reports, hospital performance reports were everywhere. It was the big thing. And I was working on that at the University of Toronto. And what I became interested in after the second report was it's great that we're putting all of this money, and there was a lot of money going into producing these reports. But I was sort of left with some lingering questions about, whether or how these hospitals were actually making any use of these data at all. And that's what interested me as a grad student, and that's what I studied for my PhD dissertation. And then I sort of moved a little bit more after I graduated and postdoc and early research career to looking at, the role of culture in organizations. So not national culture, but sort of organizational cultures, and the role of culture in quality improvement and patient safety and use of performance data and things like that. My training was in organizational behavior, so I've always been interested in kind of had an org culture lens, a leadership lens. Interested in the conditions of work, worker satisfaction, retention, that kind of thing. And then I would say in the second decade, I moved like a little bit more into the KT world, more broadly to say, it doesn't matter if it's hospital performance reports or if it's data on, patient safety problems. We had sort of a landmark report came out of the US around 1999 to Error is Human and all the healthcare errors. And we had similar studies in Canada and other countries. So whether it's performance data, safety data, quality data, research evidence, I just became interested in, okay, how do people in the system actually make use of these data and evidence? Didn't matter what kind it was. And so that's sort of where I moved, in the second decade. And then more recently, in the last decade, it was more, okay, well, can we actually design interventions to help people in the system make use of, various forms of information, evidence, knowledge, whatever you want to call it. And in doing that work, I became, more aware of and interested in the complexity of actually changing systems to improve care, and the importance of context. And so the frameworks that I've used, well, we used kind of Parish early on, and I'll talk about that framework. More recently, it's frameworks that recognize or center sort of complexity and the importance of context. So that's just kind of like a tiny little bit about where I come from and the lens that I bring to this, which again, I think is important because those of us who work in this area come from very, very different spaces. So almost all of the research that I do is sort of now in living health systems, which, as I said, are complex, and so are the people, and so are the dynamics. And so Inform and Scope are two interventions that we've been working on most recently. They're both focused on ways to improve care and quality of work life in the nursing home sector. Both of these interventions employed kind of facilitation at the sort of unit level as a way to help teams implement change, improve care. And I'll talk more about facilitation and what I mean by that. Um, and both of these were trials. They ended up being pragmatic trials in terms of the study design. But what we did alongside these trials to try to improve knowledge translation and use of evidence was we also followed the UK's Medical Research Council guidelines, which have increasingly argued that when you're doing any kind of complex intervention to sort of change behavior, to use evidence, to mobilize knowledge, these are complex endeavors, and that trials are probably not by themselves the best designs for studying this, and that we need to also use sort of what they call process evaluations, which are studies that run concurrently alongside a trial to help us better understand the trial. So, you know, classic trials or RCTs tell us about whether an intervention works, right? They're all about effectiveness. But what process evaluations do is tell us, well, how does the intervention work? Why does it work or not work? Sometimes interventions fail. So it really focuses more on the mechanisms of impact in a particular intervention. And I think from a knowledge mobilization perspective, this is really the information that we need if we're going to spread interventions and sort of try to see change across health systems. Um, so the other point I'll make is that we see a lot of trials. We don't see a lot in the published literature and even in the research environment. We don't see a lot of these concurrent process evaluations that take place at the same time as trials. But I would argue, as I said, really crucial for knowledge mobilization, KT or whatever you want to call it, but for our world. So I'll talk to you about one of the trial scope and a process evaluation that we did. So before I do that, this is the MRC's sort of framework for kind of process evaluation in trials. And so what they're showing us here is that the trials really focus on the stuff in the gray boxes, right? So we've got some kind of intervention and we're interested in an outcome. So that's the effectiveness question. Does a particular intervention work? Yes or no is the answer that we'll generally get from those studies. But the process evaluation really informs the interpretation of those trial outcomes. So that's all the stuff in the green box. That's what we're doing in a process evaluation. And it tells us, why did the intervention work or not work? As I said, how did it work? And it does so by looking at a number of really, really detailed things. So it looks at aspects of the context. So the top part of their model is, really focused on things about the particular study context that are going to influence whether or not they're successfully able to implement an intervention. It's going to look at some of the causal mechanisms, how they work in that context. In the implementation box, it's going to look at things like how do teams actually go about the work of implementing this change? Do they do it with fidelity? In other words, do they implement the change in the way that it was intended to be implemented? Sometimes we have knowledge that's generated through, original studies, and by the time it gets deployed out there, mobilized, the intervention that's actually being implemented doesn't really resemble very closely the original sort of intervention. And so that's a fidelity question. So we often concern ourselves with questions of fidelity. And then it looks at, as I said, sort of the mechanisms of impact. How do the participants feel about implementation? Is it acceptable to them? Are there unexpected things that happen? So you can see there's sort of a lot of detail in the green boxes, and that's really the process evaluation that the MRC says we should be doing as we do any kind of trials if we want to understand implementation and uptake. So as I said, I'll walk you through a process evaluation that we did of a complex intervention called SCOPE over the last few years. So SCOPE stands for Safer Care for Older Persons in Residential Environments. It's really a quality improvement intervention. And what it did was really empower the care aides. So in Ontario, we call this group the PSWs, personal support workers. So these are healthcare aides who provide, more than 80% of the care in nursing home settings. The idea was to bring a QI intervention that empowers those particular frontline providers to really take a lead role in implementing changes on their unit to improve care for residents. So what we did was we taught the care aid teams about some of the basic sort of principles of quality improvement. We taught them a particular QI technique called the Plan, Do, Study, Act, or a PDSA cycle, which are little small tests of change to bring about improvement. We taught them how to collect local data so they knew if their changes were having the intended effect. Part of scope included, because we were using that parish facilitation model, a lot of facilitation. So these teams got help not only from their managers who had a formal role in the study, but also from an external quality advisor. And these were folks who came into the homes, met with the teams regularly, and really helped them to learn how to do the QI work. And the other part of this scope intervention was modeled after the Institute for Healthcare Improvement's breakthrough series model. And this is it's a learning collaborative. So there were many teams. There were about 30 nursing homes that participated in scope. We would bring them together periodically throughout the intervention every few months so that they could share what they were doing in their teams with other nursing homes. So there was a whole sort of multi-pronged approach to teaching these teams to improve care for residents. And it sort of looked like this. This is just a bit of a graphic that shows. So essentially, we had a series of these formal learning congresses, 1 through 4, where we taught them about QI. Then they had these sort of facilitated action periods between the congresses where they implemented their little PDSA cycles with the help of the quality advisor and with support from their leaders and mentorship and coaching. And then sort of they would come back at the third and fourth learning congresses, present on their progress, learn a bit more, try different tests of change. And so, as I said, the scope intervention was guided by sort of a pretty well established, well used implementation science framework, which is the Parish framework. And Parish is really both intended to help explain and predict why implementation of evidence into practice is or is not successful. And there's really 3 components to Parish. They argue that if we want to have kind of successful implementation of evidence, we really have to have sort of good quality evidence. So that's the top circle here. The characteristics of the setting are really important. So that's that attention to local context. And then the other key thing is that we need to have facilitation. We need to help the folks who are trying to implement evidence in their context. We need to help them. Essentially, they need facilitation from folks who have, skills in whatever the area is. There's been some critiques of this framework. It came out sort of probably before 2010, sometime between 2005 and 10. A 2015 paper sort of critiqued it by sort of suggesting that we don't pay enough attention to the role of individual people in here. There's lots of people operating in these models, and where do they fit in? And we probably need to elevate facilitation. It should probably be a bigger circle. They think that maybe is maybe the most important piece here. So that's sort of one way in which we use a sort of a long-standing framework in the scope study. Um, so I described it. What did we find in the end? Well, the trial was actually sort of an unsuccessful trial, according to sort of our primary outcome in terms of whether it was effective. So what we were hoping to see as our outcome, which is the care aides reporting greater use of best practices, we didn't see that happen. But what we did see is that both the care aides and the managers who were involved in scope, and those of us who were there at the learning congresses and working with the teams, what we saw was something that actually looked to be quite successful. The staff seemed to think it worked. They felt it was having improved benefits and outcomes for residents. And so we were sort of left with this question of, well, is it a failed trial or was it successful? And how do we know what was the reality? And so this is where the process evaluation really came in as a helpful way to enable us to understand this a little bit better. And so we looked at things like, how did the teams do this work? How did scope produce change that we were trying to produce? What were the mechanisms of impact? Did they implement it with fidelity? Did they implement it the way they were supposed to? And so that's what the process evaluation did. And so the particular aims of the process evaluation were really, we wanted to come up with a program theory. And a program theory is just a theory about the way a particular intervention, is working. So it's very specific to one kind of study or context of a particular intervention. And so we wanted to develop that program theory about how the implementation of interventions like scope take place in nursing home settings. And then we also wanted to test parts of that model statistically. And so I may or may not have time to get to the second objective. In fact, I won't have time to get to the second objective looking at my time now. So how did we sort of arrive at this? As I said, we studied all 30 teams. We used a mixed methods approach. We had a whole range of data from the teams. We interviewed them. We did focus groups. We had them complete little surveys for us at the learning congresses. The quality advisors kept extensive diaries about how the teams were doing. So we had a really rich mix of kind of mixed methods data that we were able to look at. And we looked at several implementation outcomes from Proctor. This is another really useful framework. Was the intervention acceptable to teams? Was it feasible? Did they implement it with fidelity? Etc. And in the end, we came up with a program theory that sort of looked like this and had uh, sort of we felt there were kind of four interrelated processes that really described how these teams implemented this complex intervention. And so I'll give you just a kind of a single quote from each of them. So one of the first processes that we saw was teams obviously had to kind of learn and apply the QI knowledge and skills. That was the kind of the core component of the intervention. And so this is a quote from one of our focus groups about sort of how they engage meaningfully with this concept of the QI tools. So someone said, QI isn't anything to be scared about, right? But it's a language that people don't speak. So I think it's about making it a language that people do speak because it's not rocket science, but it's just about making improvements. So really they needed to sort of grasp that and engage meaningfully with kind of the concepts of QI. The second process was about negotiating relationships. So there was a lot of the interpersonal here in developing and fostering relationships. And so, as someone said, they had to develop positive team dynamics and cohesion. So one person described early on, this was an observation that we made. She said, we got all this top-down SHIT dumped on us early on, but now we have more freedom and it's functional. And so someone else said, we had to maintain that team. She said, the other staff didn't know what we were doing. So they'd say, I'm not getting anything. Why are you wasting your time? Why are you wasting our time? And to change that attitude and convince those people took a long way. So they really did have to do a lot of work, kind of negotiating relationships if they were going to successfully implement their scope work. They also had to navigate their workspaces. So this is where someone says their senior leader, sort of they were supposed to help find capacity for scope. And this diary entry from a quality advisor says the senior sponsor appeared annoyed. They looked tired and they stated that they'd been exceptionally busy due to accreditation, staff shortages, and other QI projects. So they were supposed to be getting the support from their leadership, but in this case, they really had trouble navigating these kinds of other competing priorities. And then the last process was this sort of shifting culture, shifting roles of the care aides. So enhancing empowerment, building trust. One of the managers said the following at a focus group. She said, I've seen huge capacity for change. Honestly, like she names one of the care aides, presented scope at every single mandatory education we had for all staff in the month of February. I would venture to say it's the first time a healthcare aide has ever presented during mandatory education. So there really was this kind of change, fairly fundamental change in the way these folks saw their roles providing care in the homes. There were things around reducing tension and conflict, so I won't sort of read all of them. Um, the next thing we wanted to do, as I said, was sort of test aspects of this qualitative findings in a more quantitative way. And so I will walk you through just sort of one piece that we looked at here. We looked at fidelity. Did the teams implement scope as intended? And we had a quantitative measure of that. And what we found was that there were really three other quantitative measures that were related to implementation success. And so teams that found scope was beneficial for residents, they were more likely to implement scope with fidelity. Teams that had strong leadership support, they were more likely to implement scope successfully with fidelity. And finally, teams that had where priority scope was a priority in the nursing home, they also were more likely to implement. But we found this kind of interesting relationship. So on the one hand, we see a relationship here between, if the care aides believed that scope was good for residents, they were more likely to implement it. So That's what we would hope, and we were happy to see that. But what we found is this relationship actually depended on the level of senior leadership support. So for the teams that had sponsors who were really, really supportive of the care aids, that's the red line here, implementation of scope was very high on these teams, even if the care aids didn't feel scope was beneficial for residents. So when team sponsor was low, which is the blue line, we see that relationship come back. And so what this signaled to us is just how crucial and how much impact the leader's role and the support is, and how much of an impact that can have on the carried's ability to implement initiatives like scope. So I'll come back to why this is important as I sort of wrap things up. So as I said, this was a negative trial. It didn't have show the effectiveness results that we were hoping to in the RCT results, but our qualitative data suggested something very different. And that was that this was a successful trial in a lot of ways. The program theory really said that, we think frontline teams can implement complex interventions like this, that implementation is facilitated when they engage with those core components. And also it's facilitated by leadership and those relational things, right? The navigating relationships, navigating workspaces. They found that implementation was also facilitated by these shifts in role perception. So when managers really had a belief in the carried's ability to do this work, that helped a lot. When carrieds did the work, their efficacy, their belief in their ability to do the work increased, trust increased with their managers, and then also things like the perceived benefits also fostered implementation. And so, we're kind of left with this question about, well, all right, well, what's unique in this work? So as we said, not a lot of concurrent process evaluations are done with complex interventions. So I think this work is signaling some of the more direction now to do kind of longitudinal studies, process evaluations that really look at implementation trajectories as they're happening over the course of a year or so. I think our piece was unique in using a true kind of mixed method design. We had data from all of the participants, the quality advisors, the care aides themselves, the managers, the researchers who were observers. And then the other thing that it did is it allowed us to hone in on other things. So because of that sort of interesting leadership finding about how important that leadership piece was, we went on to do some further analysis of just, okay, how does the leader role play out? How can we build leadership to support teams, to promote implementation? And what about fidelity, the way we measure how well teams actually implement interventions? Can we measure that better? And so there was a bunch of sort of spin-off work here. In the end of the day, we published the program theory in the Gerontologist. We published a further study that honed in on that leadership stuff in BMJ Quality and Safety. And we took this quote from one of the managers that it says, "We listened and supported and depended on each other." And that was kind of the essence of how they enabled these teams to succeed. And then we had also published a measurement paper that's around kind of fidelity, which is less interesting to most people. So in terms of the frameworks, Michael asked me to talk about frameworks. I sort of briefly referred to them throughout, but some of the key ones that I think are sort of helpful to keep in mind. I think that the MRC framework really for evaluating complex interventions, I think is an important one for any kind of knowledge mobilization work, is just looking at the how interventions work and not just whether they work. That when we want to look at how to mobilize knowledge, we need this process data, this mechanism, understanding of the mechanisms of impact, how things work in specific contexts. I think the parish framework continues to be really useful. They identify the importance of context, they talk about evidence, and I think the facilitation piece is really key. We've gone on in the most recent year to kind of do a new version, an updated version of Scope, where we actually add more facilitation to try to help teams this time in Manitoba to be more successful, because teams still really struggle with this stuff. So I think the parish framework is still really helpful. If you kind of go back a bit, I referred to some of the Gibbons work, the Mode 2 stuff, or the knowledge to action work. So just in any knowledge translation work, mobilization work, it's recognizing the importance of these linkages between the researchers and the users. We can't function in different sort of spheres. We can't function independently of one another. Researchers don't have knowledge of the user's context. We don't understand their values. We don't understand their workplace challenges. And so we can't have meaningful knowledge mobilization without this kind of mode two or integrated approach. Um, the IHI collaborative model, I just put the reference up there. It's a great model for making small scale improvements in complex contexts. So I refer to that. And then the last one is the implementation outcomes framework. And this was done by Enola Proctor and colleagues back in 2011. It's still very, very widely used. It's an evaluation framework. So if we're doing kind of knowledge mobilization or implementation of new practices, it's important to look at all of these sort of implementation outcomes. Is the intervention acceptable to the people that we're asking to use it? Do they adopt it? Is it, make sense from a cost perspective? Is it feasible? Is it implemented with fidelity? So Proctor and colleagues have 8 implementation outcomes in their framework, and I think they're really quite useful. There are other frameworks. There's a consolidated framework for implementation research. There's others. These are the ones that we've drawn on in our own work, and that we've found particularly helpful. Um, I'm at 30 minutes. Michael, I've got like 2 more things, but I feel like I've just kind of droned on here maybe more than I wanted to. Maybe it's because I'm just looking at a blank screen and I can't see your faces. But should I just kind of wrap it here, or do you
No,
want
feel
me to
free to
talk for?
no, feel free to take some time and wrap it up, Leanne. We're not under any time constraints, so yeah,
Okay.
take
Okay.
the
So
time
I
you
guess,
need. Thank you.
the last thing maybe I'll just mention is sort of, all right, well, what have we done since then? And in particular, when we were thinking about sort of theories, models, and frameworks. So I showed you that sort of interaction graph where we found that leadership was really important. And even if teams didn't think this was helpful for residents, if they had really strong leadership, they were implementing scope anyway. So that was sort of drove us to say, okay, there's a lever here with leaders. We know leadership is important in so many contexts, but what do the effective leaders look like in these scope teams? What are they doing to support these teams? And so we did sort of those analysis, and we found, that really what they're doing is they're creating kind of a culture of empowerment, and they're doing it a few different ways. And so we published that to really try to open up the black box of leadership in implementation. And it's sort of a pretty dynamic model. So rather than just listing the leadership characteristics, it talks more about kind of the things that they do and how they behave, the ways in which they kind of foster change to be sustainable, the ways in which they themselves adapt. I mean, they talk about the successful leaders that we studied really talked about changes they themselves underwent as part of scope. And one of those changes was they developed a new appreciation really for the skills and abilities of these curates. And so that was sort of an interesting, I think, thing for them to experience. And they also talked about building a collective identity around the intervention. In this case, it was scope, so that teams really everybody bought on, and that was a big part of what the successful leaders did. So, when you and we used again kind of some of the leadership theories from organizational behavior to help us sort of understand this. And then the last thing that we're doing, so this came out of the scope stuff. And then I mentioned the work we've done sort of within the last year in Manitoba, which is kind of the latest iteration. We actually added a new attempt to help these teams. So the teams still really struggled with a lot of the details of the PDSA work, that model for improvement. How do they study their processes, measure whether the changes that they're making in their care home are actually leading to improvement? They struggled with some aspects of that measurement piece in particular. And so one of the theories in implementation work has to do with readiness for change. And it's, this whole conversation about, is every nursing home ready to do a project like Scope? Or are there some homes that have a higher kind of level of readiness that we should be trying to understand before we just kind of, go in and implement these sorts of things across the board? And so what we did was we added kind of the theory around readiness for change in our Manitoba homes and said, all right, at the beginning, we're actually going to try to promote readiness in these homes before we do any of the scope stuff. We're going to recruit them in a more meaningful way. We're going to talk about readiness. We're going to assess readiness. We're going to try to build readiness if it doesn't exist. And so we drew on that readiness theory. And so this is the original model, readiness for change model from Brian Weiner, 15 years old. I'm not expecting you to read it, but basically what they say is that org readiness is made up of two things. So organizations that are ready have a high level of change commitment and they have a high level of change efficacy. And change efficacy, by that I mean the organization believes they have the ability to implement the change. Okay, so if you want places that are ready, they've got to be committed and they've got to have a high, strong belief in their ability to actually implement the work. And so, that makes intuitive sense to me as a human trying to get people to do things differently. And so we went in and we tried to assess commitment and assess efficacy and promote it before we did scope in these 11 homes. Then we did it for the next year. We studied the 10 homes in the same way that we did in scope. But we found something kind of interesting. And this is what we're writing up now. So here's kind of the readiness piece, the way Weiner and colleagues defined it. But the idea in the original readiness for change model is that this is something that we want to address before implementation, before mobilizing the knowledge, if you will. That there's a level of change commitment and change efficacy that exists before you go in, and let's understand it. And if places aren't ready, we either don't go in or we help them to become ready. So it's kind of the idea that it's a static variable that we assess kind of at baseline at the beginning of, mobilizing knowledge. But what we found was actually, the stuff that's taking place behind this arrow here, this is a whole process of how readiness emerged throughout the 1 year during which these Manitoba teams implemented scope. So it sort of questions this theory of readiness that says it's just baseline and it's either there or not. What we found is actually the very act of implementing scope has an influence on readiness. So, for example, when teams were really successful and felt residents' care really improved, that boosted their efficacy, their belief in their ability to do it, and boosted their readiness. So we're just sort of, when you bring in some of these theories, especially newer ones, and I would argue that readiness is a relatively new theory, even though it's 15 years old, it's not terribly, extensively tested. So we're, I think, maybe able to make a little bit of a contribution to this theory to say, it's not only baseline, but actually it's something that's going to develop through an intervention too. And so I think this is the kind of way in which theories, models, and frameworks can also be used and updated in the process of implementation. And I think it's important because, as we said at the beginning, implementation science is a relatively new field, right? So some of these theories, they're not grand theories that have been around for 4 decades. They're newer ones, and there's got to be room to adjust and adapt and update and improve these theories. So I think I'll sort of stop there. I've got sort of these are references just to some of the theories, models, and
Okay.
frameworks that I referred to. Happy to share those with you, Michael.
Thank you.
And yeah,
That'll
I'll
be great.
stop there.
Leanne, do you have a bit of time for questions?
Sure. If I haven't put
No
everyone to
problem.
sleep, I'm
No,
absolutely
no, no.
happy to answer them.
I'll actually ask the first one, give folks a bit of time to queue up any questions they have. I'm always fascinated and daunted by this space. And maybe it was when I started back in 2006, and it was around the time that Dr. Graham and his colleagues, the Knowledge to Action cycle came out through the Canadian Institutes of Health Research. And I was fairly intimidated because I couldn't understand where it started and where it ended. It wasn't intuitive to me, but people seemed to be cool with it. And I was kind of quiet because I was new. So my question relates to the literacy of implementation science. It is a growing scholarly field. There's a CRC in this space. It is important in the overall landscape of knowledge mobilization. It's are you finding collegially within a work team that there is a growing understanding about the emergence of new models and implementation science overall, or is there still a fairly significant education and awareness piece?
So it's a great question, Michael. I think so a couple things. I tell my grad students this, and it's because it's true. Often when I allow myself to kind of really think about some of this stuff, whether it's the K to A model or how this all fits together, or where some of these spaces overlap, if you want to get into the KM versus KT versus
Right.
IS or whatever it is. Like it makes my head hurt. I don't like I feel overwhelmed. And I feel like that's kind of weird because like I spend the vast majority of my research life, in some way in this space. And yeah, I do a lot sort of in the methods and the design space here too, which is more the IS, right? It's the study of KT. But every time I come back to get ready for one of my lectures for my grad course, it's like I reread the stuff and I kind of feel a bit overwhelmed. And so I say that in response to your question because I think that this, because perhaps because it's a relatively new field as far as fields go, perhaps because it's so interdisciplinary, it draws from so many different spaces. I think we're in a really early stage of development and understanding around this stuff. I also think that what we try to do with KT when we try to mobilize knowledge or translate knowledge or change practice, which is essentially what we're doing in all of these, right?
Right.
That we're trying to do it in scope. I think we're working in such a complex space, and it is such a difficult thing to do, that we're very much still in that we don't even know what we don't know. We're still discovering what we don't know, you know? Um, and
That
so
it,
I think you're feeling overwhelmed. I think that's
yeah.
not uncommon.
Oh, I mean, and I really value the honesty. It's because in those early days, and I mean, I had been, let's say I was working in the field for about a year or so, and all of a sudden I have a fair amount of tenure in relation to new and emerging knowledge brokers coming on the scene at other universities. And we talk about this, and I'm like, I'm a little bit scared to say I have no idea what this knowledge to action cycle is because I don't know where it starts. I don't know where it ends. It's not intuitive to me. Context is key. I suspect when you're working with a project team, like you shared a number of them, and there's context around all of them, that it would become a lot easier for people to understand once they're actively engaged in those processes. Once you participate in that space and can see, like the one that you shared, where there's context at the top, well, that, I mean, that's critical, right? And the way in which the arrows move, some of them are bidirectional, some of them are one way, and just once you see it as a more dynamic organism. So thank you. There's a question in the chat from Kayla. I'll read it out. How much regional variation do you see? Would the same model or methods work in a country with very different culture, social norms, etc.?
So are you referring to the stuff that we like, particularly with, say, care aides and nursing homes, but in other jurisdictions or countries?
Feel free to jump on, Kayla. I would assume that to be true, Leanne.
Yes, please. Although we're looking at it this time from political interventions, but I think learning from your experience would be really helpful.
Yeah, so I think for us in the Canadian sort of settings where we've done this, and we've done it across Western Canada, and there's actually, quite a bit of difference between even Manitoba and BC these days in terms of funding and things like that. But I would say that those differences are almost non-existent compared to some other health systems. So I would think that there's probably a decent amount of, you know, external validity or generalizability of our findings to other um, publicly funded systems in other countries to some extent. Uh, I think if we start getting into their global contexts where national cultures are quite different, where modes of interacting are quite different. I think some of this stuff where things like, the hierarchy that we know to exist in healthcare here in Western settings may look very different. I think most of this stuff would look very different. A lot of our learning, I think, is a key part of the context is this sort of hierarchy where we've got the PSWs who we're empowering to lead this work, and they are, for the most part, unregulated. They struggle in all kinds of ways in these settings. Those sorts of hierarchical relationships probably look quite different in other countries, and so I think a lot of the relational stuff, which is most of what we found, this is so relational, this work, would probably not be terribly applicable. That would be my guess.
Thank you. Any other questions? Here we go then. At the risk of derail, sorry, Philip, and I'll just be a sec. At the risk of derailing this, is knowledge mobilization a North American concept? Well, I've got an answer for that, but feel free to
Oh,
chime in, Leanne.
I wish you were at my class this morning. That's exactly what we were talking about today. Um, yeah, so a couple of the papers that we read today certainly said we're very sort of Western focused, paternalistic in our views about implementation, and that in, the global South and in other low and middle income countries, we've done a good job of trying to shove our models into places that they have not been contextualized, adopted, localized. So, I mean, I think I don't disagree with a lot of that. Again, I think the contexts are very different. Do I think that there's so where we landed in some of our discussion today was a few students said, and I agreed, that I think for those other regions where most of the voices that we see, the stuff that you'll read, the stuff that I've given you, these are all from people from high income countries, right? Like that's very much what's dominant in the literature. Um, and I think the argument today was that we need a lot more collaboration. I don't think we want to ignore what we've learned, what the field has learned, but it needs to be contextualized. It needs to be shared with the folks who are in those places and spaces and understand the needs, the culture, societal and political differences to sort of take and ultimately build capacity that is suitable for them. So yeah, I'm not trying to be evasive. I hope my answer didn't come across as that. But yeah, I think this stuff is very much developed in high income countries. And some of the most recent literature is saying, yeah, time to sort of attend to this better in the global
Yeah,
south because we don't right
no,
now.
no, fair enough. I use the chat room extensively, and for folks that don't really know that, you got your real taste of that today. It's almost like a little stream of consciousness, which I hope is not distracting for some folks. But yeah, I totally agree, Leanne. If we don't step back and allow for international engagement, and I think it happens in a disciplinary setting, then I think there's a risk. And more importantly, it would be great if we can involve it and bring health sciences with human services, with like and have a more process conversation. But that's um,
Yeah, and having a lot of these meetings too. I mean, someone
yeah,
pointed out today that, we have a lot of these international meetings in Western countries where, there's a
yeah,
whole bunch of reasons why we're not going to get sort of the representation from low
absolutely.
and middle income countries, whether it's cost,
Yeah,
whether it's other travel barriers. And so why aren't we doing things more locally, and they can invite in people as they want, but sort of at least sort of creating that space there. And so I'm happy. There were a couple of papers that we read for today. One was based on a conference in Bangladesh in 2019 that
okay.
was asking this very question. That was kind of a nice paper. I'm happy to share that too, Michael, and
Oh,
if
that'd
you
be great. Yeah, we
disperse.
could. Yeah, we could put it in our e-class space for those that are
Okay.
interested. Thank you, Filipina. I see your hand up.
Yes, thank you. My question is also basically how to get people to embrace change. Because what happens in my context usually is that we have the situation where we all agree that we need to embrace some of these research findings, and let it influence care. So if, for instance, I use the example of what we experience among bedside nurses, there's always the issue of burnout and high workload. So here we are, we all see that we need to do something about the problems we have at the bedside. But then the very people who would, let me say, take charge of this so that we are able to improve care are always complaining of workload and burnout. So even though they are willing to embrace the findings from research, we always come and hit this issue of workload and burnout and other challenges. And then how do we handle the situation? Because it's very complex. So many factors come into play, and at the end of the day, we have the findings, but really nothing is changing much.
Yeah. Yeah, Filipina, I think that's a very sort of astute um, observation. You know, I think it's analogous to what we see with these PSWs that we've been studying. I mean, you could, argue the nursing home sector is, severely under-resourced, understaffed. Most of these units are working short-staffed all the time. There's burnout, all of the things you say. And so how do you, in that environment, in that context, and that's where the context piece is so crucial, how do you then ask people to do anything more different? I mean, they're barely, they're not able to manage sort of their regular day-to-day work. And so I think this is why KT is such a challenge, right? I mean, at least we've come a long way in some ways, right, Michael? Like you asked about, we're
Yep,
early. Yeah, we no longer think that KT is a communication problem. Oh, if we just share the results, people will then, it's just that we haven't gotten
exactly.
the research findings into the right hands. If people know what to do, they'll just do it. No, we know that's not the problem. It's not a communication problem. Um, but I think it is so yes, there are contextual barriers that are massive that can't be ignored. And that's where some of the how do places do this work, understanding the levers, the leadership, the facilitation, the things that just might enable those same people who are burnt out, working short. Are there ways that we can help them to do things differently, not more? Nobody has space for more. That's for sure. But it's can we help them to kind of do things a little differently so that they see maybe actually this helps. This helps me. This helps my patients. This helps my coworkers. It feels like that for at least in some of our work has been the way in which some teams have been able to do this, and they have only been able to do it with the most significant, real, committed, genuine leadership. Without that, in our work, forget it. Nothing's happening.
Excellent question, Filipina. Thank you very much. Well, given the time, I think
Yeah,
what we should do is collectively offer Professor Ginsburg our thanks. Thank you for making the time to join us today and sharing your rich experience in this space, but also for your honesty. I mean, this can be a little messy, folks, so don't
yeah.
be daunted by that.
Thank you for such an amazing session.
Thank you for having me. As I said, I hope it wasn't sort of too detailed. Good luck with the rest of the program. And yeah, thanks. And Michael, we'll look
Okay.
forward to having you in our house next week. So,
I can't wait. I'm looking forward to it. I'll bring a large coffee for myself, but I am smarter in the morning, so that I
oh my.
don't know if that bodes poorly for all of you here this afternoon. But no, I'm excited about it, Leanne. Thank you. Take
All
care.
right. Thanks everyone for having me. Take care.
Bye.
Perfect. So guys, I guess now we're gonna head into, I'll let Michael take it over from here if you would
Yeah,
like.
no worries. Yeah, thanks, Brandon. We are going to get into our breakout rooms. We will finish at the bottom of the hour. I'm a stickler for finishing on time. All right, so no staying late. That's not happening on my watch. But